So I bet with all of those updates, everybody's eager to get started. So let me introduce our keynote speaker, Dr. Don Rucker. Dr. Rucker, as I noted earlier, serves as the National Coordinator for Health Information Technology within the U.S. Department of Health and Human Services, specifically in the Office of the National Coordinator for Health IT, as we know them, ONC. He has an extensive background in both clinical and informatics areas, including serving in roles such as Chief Medical Officer, co-developing one of the first electronic medical records, as well as an award-winning computerized physician order entry system. He has board certifications in emergency medicine, internal medicine, and clinical informatics. Dr. Rucker is a graduate of Harvard College and the University of Pennsylvania School of Medicine with board certifications in emergency medicine, internal medicine, and clinical informatics. He holds a master's degree in medical computer science and a master of business administration, both from Stanford. At the end of Dr. Rucker's presentation today, I will also be joined by Morgan Honey, CEO of CoRio, one of the largest HIEs in Colorado. And at the end of Dr. Rucker's initial remarks, we will have a fireside chat discussion. So this will be a virtual fireside chat. So if you have questions or comments for Dr. Rucker throughout his opening remarks, please enter those in the question field and we will take them at the end. So without further ado, I'm going to turn it over to Dr. Don Rucker.
Yeah, hi. Thanks, Melissa. Welcome to everybody out in Arizona. Obviously, we're having to do this virtually. I guess highlighting in its own way the absolute raw importance of interoperability. These last couple of years have been big years for us to really start harvesting the power of the electronic medical records and the surrounding data feeds on taking care of patients, both in formal care settings and in the community more broadly. They've just been very powerful years. We're starting to harvest what we've invested in electronic medical records, certainly a major investment from the provider side. And we're really moving, I think, to a world where patients are really empowered on their smartphone to have their data, right? That's that sort of fluid world, on the one hand for patients, and then on the other hand for providers of all sorts, that they have, no matter where they're practicing, access to complete current healthcare data, even over time, social determinants of health data that they need to take care of patients. So great progress has been made. So let me give a little bit of a progress report and some of the things, and obviously the whole conference is really about this, but let me tell you about some of the things that are maybe, I guess more Washington facing or initiated maybe. So in end of 2016, as you may remember, we just had a national election. So there was a moment of bipartisanship, and Congress almost unanimously passed the 21st Century Cures Act that basically said that that there should be interoperability. And Congress actually did three important things to really get to that vision of seamless data in ways that are empowering to patients, empowering to providers. And let me just talk very briefly about those three things, because I think they've carried forward. So the first thing that Congress said is that there shall not be information blocking. Information blocking is a term that refers to when typically delivery systems, well, for whatever reason, say, we don't really want to share data. They've been allowed to not share in certain provisions of the HIPAA law. Congress outlawed that. And they just said the base state of information is that patients can get their information however they want, wherever they want, and for the purposes of care. And that sort of, let's say, playing games with that is really not part of the equation anymore. And of course, this makes a lot of sense from a broad public policy point of view, since much of the care is really, frankly, either directly paid for through tax dollars or indirectly paid for. So it's really, we paid for this information as a country. Let's make sure it's maximally useful. So that's one big provision. The second big provision is the concept that if we're going to share this information, technically, now we're going to get a little bit very specific on part of this, that you're going to need application programming interfaces, the so-called APIs, to share that information, right? You can, I mean, there are proprietary ways to share information, but if we're going to do it for the public good, it really can't be, well, if you're using this vendor, that vendor can force you to do that, and another vendor can force you to do this, and that sort of balkanized state, right? We want, when we plug the cord into the wall, we want 120 volts, 60 cycles coming out. We don't want 240 volts. We don't want 78 volts, whatever, right? So this has been a challenge with every technology. Was with electricity before that, actually, gauge of railroads. Getting that, the railroads gauge was basically addressed with the Transcontinental Railroad, and Congress in that law also, in effect, set standard railroad gauges. That's a fascinating piece of American history, the conversion to standard gauge. That's where we are today. And so what Congress said this time around is application programming interfaces without special effort. So standardized APIs. So if you're getting smartphone data, whatever data, increasingly removing from the to the HL7 FHIR standards. This is an evolution over time. A lot of work has been built up on some of the prior things, and so we're, it's a process. The third big thing that Congress said, and this is really a tribute to the meeting that we're at today, is that the various health information exchanges really should share information, have that facilitated. And Congress came up with, as only Congress can, a long phrase that's too long for words and so becomes an acronym. And that is the Trusted Exchange Framework Common Agreement, AKA TEFCA. And so what Congress basically said there is there should be a common agreement to have these information exchanges work together. Now, as a practical matter, the information exchanges are already sharing a lot of information. There's already a lot of progress being done there. The Health Information Exchange Trade Group, CHIC, has done a lot of work. You're going to hear, I think, a lot more detail. Is the work that Arizona and Colorado are doing. So don't want to steal any thunder there, but we're really seeing a world where these things are coming together. And so that's the backdrop for interoperability in 2020. As we look at that backdrop, obviously 2020, we all know, has been marked by the invasion of an extraordinarily uniquely selected virulent pathogen that has nasty qualities to it, right? So large asymptomatic spread, well, we all know that. So in that world where we've had to go from literally ground zero, because really nothing was known about this thing, right? It's sort of, at least new to the United States. I'm not sure it was new to China, but certainly to the United States, absolutely new. And so how do we get information on COVID, right? And when we think about the types of information we need to get on COVID, it's a lot of different information, right? So we need information about, the care of patients with COVID, who has COVID, what kind of medical problems do they have, what kind of resources do we have to help address their care. But beyond that, because this is again, new to the United States pathogen, and new to the new to certainly Western science. We also had some deep biologic things to ask and answer, right? So learning more about its transmission. What are the risk factors for getting COVID? What are the risk factors for complications? How long does it last? Basic questions, can you get reinfected? Obviously, we had to go from ground zero. We've never had a test for COVID, right? So don't have a test for things you don't know, somewhat self-evidently. I guess this was a point of contention in some quarters, but we had to, from ground zero, figure out how do we test this? And then we had to figure out what's the performance of the test, right? So, when does it turn positive? When does it turn negative? Related tests on immunity. And then all the other biologic questions on things like, so for example, what are downstream complications? Are there going to be issues with the vaccine downstream, vaccine performance? And as we sit and think about all of these questions, and there's bits and pieces and sources for things. I know a number of folks on the audience here have had to do mandated reporting to various probably state and federal agencies on this. And mandated reporting obviously has been the way that public health has found information about illness for literally, I think, since John Snow and the cholera water pump in London back in the 1850s. But as we look at the theme of the meeting today, we now, with all of this interoperability, have a new way of thinking about that. And HIEs have absolutely been on the lead here, because what health information exchanges do, the HIEs have the unique opportunity in a privacy protecting way, because, and we're talking now about the state and large locality HIEs in some parts of the country. Arizona, fortunately, has a single HIE, so kudos to Arizona for that leadership. But as we look at the health information exchanges, they're in a very interesting position because they share a lot of information with very powerful legal protections for the public, with local accountability, not just on privacy, but on performance, on network connectivity, on availability to state public health agencies. So a very powerful construct, and they can answer some very interesting questions because they really are deep in care. So they can do something which is give a longitudinal picture of individual patients. So the questions I just outlined earlier for the audience are really questions where you have to follow a patient over time, right? What happens to the patient? What are their risk factors? Let's say you get a test in a drive-by testing thing. How do you correlate that with somebody's race and ethnicity that, drive-by testing wouldn't have a way to really effectively, efficiently, and economically collect? How do we put all these things together? How do we look at downstream effects? How do we even look at test duplicates? One state HIE number of weeks ago identified that a third of the positives are actually duplicate tests, right? And that's understandable. People get positive, they want to know, am I still infectious? Am I still positive, right? So, we know how that plays out. And because health information exchanges have patient identifiable longitudinal data over all providers, right? Not just you purchased a certain EHR, but whether you're in the hospital, in the clinic, you heard about long-term care facilities, wherever you are as HIEs build out, all of that information can come together so we can track illness wherever it presents itself with health information exchanges. They've really shown an extraordinary ability to answer public health questions. We at ONC are doing a lot of work to advance this as part of interoperability. As folks may know, we released on the things we talked about at the very top of the conversation on information blocking and application programming interface without special effort. We released a large, unfortunately large, but a lot of details here. Interoperability rule on these requirements. Over the next several years, there will be some delays in these implementations, obviously because of the immediate COVID pandemic. There's been some delay there, and it's folks who are Beltway folks may know. We have further timing work in progress at OMB to adjust for COVID. So that rulemaking is out there. The Center for Medicare and Medicaid Services, CMS, has companion rules on interoperability that we as an administration have put together to really make this picture a seamless picture to empower the American public, to get the American public in control of healthcare. These are exciting times. They're scary times. They're times where we need vast amounts of information to, frankly, keep ourselves healthy, not just for the folks who have the COVID and need to, get treated and get care, but, as we try to prevent as much transmission as we can, as we wait for, the vaccine testing to happen, to be rolled out. A somewhat little known fact, maybe not, is a lot of the vaccines have, there are millions and millions of doses of vaccine that have already been manufactured and that are literally just waiting the testing programs to show whether the vaccine is effective. We're pretty optimistic about that because this is the first time in history, literally in history, that we've been able to harvest the literally 20, 30 years of massive national investment in molecular sequencing and cellular understanding to build these things from first principles in biology, in DNA and RNA. So exciting times, a lot of things to connect. It's a tele world, and I'm so pleased to be able to speak. And I think, let me turn it over to Melissa and Morgan to put me on the spot, maybe with anything I might have danced around. We wouldn't do that in DC, no, just kidding. I wish everybody well. I have a bunch of family out in Arizona, so wish all of you very well.
Well, thank you so much, Dr. Rucker. Really appreciate those opening comments. To kick us off with some questions, we appreciated your comments at our SHEET conference, and that audience was largely HIEs and different stakeholders in the HIE space. Today, our audience is more our Arizona healthcare stakeholders. So what advice would you give to the various healthcare communities throughout Arizona when it comes to things like information blocking and preparing for TEFCA? All of these things impact different stakeholders in different ways. I know for information blocking, we've been trying to educate our community, make sure everybody has the resources they need. But any pointers or suggestions you would have for those stakeholders to make sure that they're up on the latest and prepared?
Yeah. So again, with rulemaking, there are timelines and conditions. And if you go to healthit.gov, we have a vast amount of resources there on some of these things. I think a lot of it just is, do the right thing. We've designed all of these processes and programs to really make this ideally as seamless for the providers as possible. So let me be a little clear on what that means. So in the individual APIs for smartphones, using certified electronic medical record products, basically, we're talking about a server and an endpoint on the internet with all of the privacy and security of OAuth 2 that if you have a provider portal, you are already using, right? So the point there is to stand up that endpoint, and then smartphone apps, if the patient wants it, can access the data. And again, the point is not that you have to produce a lot of paper records and go to the file room. This is, essentially seamless unattended once you put a server up, that we anticipate EHR vendors will all do as part of that. A relatively straightforward activity that can run in the background. And the same way with health information exchanges, and of course, TEFCA adds to that, we are building a world, and I hope and believe you're seeing a world in Arizona. Once you have hooked up to Health Current, that is a relatively seamless process for you. So you don't have to send more things to Washington. You don't have to have somebody running around collecting data on, clipboard spreadsheets. We've tried to make these things so they leverage the electronic work you're already doing. The important part of that from a data point of view, that's from the provider point of view, the folks, is that's the best data, right? Because that's data that has eyeballs on it, has a process, goes through the quality, the QA, data shepherding, patient matching work that the HIEs do, that Health Current does. So that's what we've done. We do not have an explicit provision in there that, full participation in HIEs, a total get out of jail free card. But I think, that would be a very, very important thing. The actual enforcement rules are not out yet. The Office of the Inspector General has not, they are going through comments on things. The disincentives to providers, as the law puts it, have not been released as proposed rule. So as a practical matter, these things are not immediately enforceable. But we think with these APIs, that's going to be the world where these questions, honestly, we hope become moot. But again, healthit.gov if you want a lot more specific details.
Great. And I probably would be remiss if I didn't have one follow-up question. I know there have been some requests to delay the implementation information blocking rule that's right around the corner. Do you have any updates or predictions on when we might hear about any potential delays?
There are many, many, many laws in DC, and one of them is called the Administrative Procedure Act, which sort of ties my hand on what I can say. But I will say in a broad way, we're obviously working on COVID and the issues around COVID day in, day out. Melissa and Morgan, you know that exactly because we're stealing you away for a call later today on a meeting with some of the folks in DC on that specific topic. When you put out rules that change the dates, they have to go through a process called clearance that has many, 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 many pieces to it. Much of it is actually for the public good. It means that there are a lot of eyeballs on public rules and a lot of thought, but it certainly doesn't allow for anything speedy, I would say. So we publicly said we have a rule that in its title notes timeline extension. So I can't say anything about the timeline extensions till the rule's out, but I think for folks to read the title, it shouldn't be really hard to think of something that is sort of, modulo sort of the delays induced by COVID. We'll let everybody go back to their math books to remember what the modulo function is. It does bring up the broader issue though, which is, had all of this happened a couple of years earlier, we would be in much better shape on COVID, right? We would have, for example, if you're a telehealth provider, you would be able to get from your HIE all of the information on that patient who's, quote, virtually in front of you. So rather than spending 20 minutes getting part of a crappy history of somebody's medical care, you'd have a relatively complete history of their medical care. So I think it, timing is would have been better to have it earlier, but I think, we're we're moving, I think, in a way that, Moore's law and computer power doubling every 2 year type of thing. I think we're moving on a trajectory in healthcare that allows us to benefit from Moore's law. I know they make some of those products down in Chandler, so you guys are part and parcel of the product, part and parcel of that. The reason I know that is my brother works at Intel down in Chandler. That's a family insight. Had nothing to do with interoperability. So at any rate, yeah.
Well, we really appreciate all the efforts of your team and the HHS teams in advancing all these interoperability things. I agree with you. It is a balancing act. It would have been nice that some of these things were advanced a couple of years ago, but hindsight's always 2020. So we're committed to supporting all the information blocking provisions and everything that we can coming out of the CMS patient access and interoperability rules. So I just knew it was of interest to our stakeholders, but we will hang tight and keep an eye out for that news when it's available. So let me turn it over to Morgan for the next question. And before I do, just a reminder to those that are viewing the online portion, you can ask questions right below the screen where you're viewing the presentation. There's a chat function. You can enter a comment or a question there. We will receive it and we will incorporate it as part of this discussion segment. So Morgan, over to you for the next question.
Thanks, Melissa. So Dr. Rucker, I'm going to pivot a little bit and ask you more of a HIE landscape question. So, you're very aware of all of the activity going on between HealthCurrent and Coreo. And you've talked a little bit about, participating with an HIE is not a complete get out of jail free card. We would love for it to be a get out of jail free card. But we've got a lot of folks on the phone, and particularly one of the driving issues in our partnership was the fact that we do share a lot of clients, and there are a lot of folks on the phone who may not only operate in Arizona, but I can think of Common Spirit, Banner Health, among many others that right. really operate either regionally or nationally. And so my question really is about when you are thinking from a federal perspective about the needs in terms of particularly COVID monitoring and reporting. One of the great benefits that we have as HIEs is that we aren't on the front line trying to combat the virus. We are very much behind the scenes dealing with the data and all of that infrastructure. As you look at the landscape and you think about the conversations that we've had, where do you see kind of HIEs being able to evolve into a place where we can serve more as that centralized data reporting process, so that the folks on the front line really can focus on the front line and not have to deal with the burdens of data reporting or submission? Just generally, where do you see from the federal perspective the HIE landscape evolving to?
Yeah, obviously that's a huge question. We can spend the rest of probably the entire event talking about it. I think, one way of looking at this, a number of the HIEs have as you're aware, really modeled is really the utility, public utility sort of viewpoint, right? That you are a relatively seamless, just like we have the electric grid. And I think there are actually a lot of lessons to be learned, right? So in the electric grid, we have standards, and that includes in healthcare would include HL7, TEFCA maybe as part of that. We have cross-state electricity grids, right? We have total U.S. interconnect of power companies using different modalities to generate power, different utility companies cooperating. So I think these things are increasingly going to come together over time. And I think, the fit and finish of these things is rapidly evolving. So this becomes more and more seamless, the entire transition from data getting into the record to, data being shareable under the various privacy provisions, that as all of these things become, the data becomes better, the the terminologies become better, the APIs become more robust, the back end that you're doing, evolves, the ability to find patients across country, sort of what's called broadcast query, those types of things evolve. So I think they're all works in progress. What I think is powerful about, the sort of the state scale health information exchanges is worth pointing out here. So a couple things. One, they're not dependent on specific EHR vendor products, which I think is important. Two, they really can incorporate all comers, right? So it's not just doctors and hospitals, but certainly as an ER doc for 30 years, there's a huge set of behavioral health, jails, schools, homes, shelters, nursing homes, long-term care facility, home health care, lab tests, lab companies. There are all kinds of folks that we really want to have starting to be in these exchanges who are part of providing care to patients. And a lot of this is highly governed by state law and state regulation. So I think the having, sort of state granularity on this is very important. And in fact, it's the same way it happens in public utilities and rate setting things. So I'm seeing, that the HIEs are, nonprofits, the ones I'm talking about. So I'm seeing them really becoming even further and further. Of course, that has great benefits. It means the information is more reliably there. It will anneal itself to be, more easily accessible. It will make it a much more seamless experience for patients and the public that they can get care wherever. And so that's I think a huge opportunity here. So yeah.
Great, thank you, Dr. Rucker. There has been a question and a comment actually that's come into the chat, so I'm going to turn to those.
Sure.
One is a comment on your Moore's Law reference. The comment is, Moore's Law still so true. I appreciate that remark. And then the question is, and I think this is an interesting one, especially as we look at the impact of various previous requirements when it comes to electronic health records and that impact on COVID and our efforts going forward, is do you think that the meaningful use requirement for syndromic surveillance to BioSense2 impacted the COVID result in a positive way or not at all? Are there some lessons learned in terms of how we translate essentially some of those previous requirements into making sure that they can benefit us going forward in these types of scenarios?
The Moore's Law thing is, I think, the story of our lives. So that's actually worth understanding. That was actually an article that Gordon Moore, one of the co-founders of Intel, wrote in 1965 and predicted all the way out for another 10 years that chip speed would double every 18 to 24 months. And, through a variety of technologies, that's roughly held true for, a lot longer than 1965. Tell me the second part of the question.
The other one was about syndromic surveillance.
Yeah.
And whether
So I think the syndromic surveillance highlights both the opportunity and the challenge, frankly. So for folks who don't know, CDC has a syndromic surveillance thing that, for example, looks at ER chief complaints that is really, I think, gated around respiratory illnesses, frankly, right? Sort of flu type of things, if you will. I think there's certainly been information there. There's certainly that provides backdrop. It will certainly be, as we come into flu season, where the separation of COVID and flu data is going to be challenging, I think, biologically. It's certainly helpful, but I think it brings up the broader role, which is we should probably not really, as a general rule, rely on disease-specific silo reports, right? The reality is we don't know the shape of pandemics, right? COVID took one shape, but there are many infectious agents in the world. There are many other, they're chemical agents, right? So we don't, we should not make assumptions about the nature of the pandemic, the nature of the organisms. So I think we want to have data capture things that are really eclectic and can get symptoms no matter what the presenting symptoms are. We don't know, and do it in a way that we can discover these things as early as possible when certain symptoms spike, even if they're not necessarily the ones that we're looking for. So I think this highlights the opportunity, if you will, to think of pandemic analysis as a big data type of world where there's, machine discovery, maybe even neural net discovery, machine learning. We're able to put new technologies on this discovery of things and monitoring so that it's both more predictive, more accurate, and frankly, less burdensome. So I think it sort of highlights, some good things in the way historically is done, but also points the direction in a totally new opportunity.
Great. I know that both CoRio and Health Current have been working both historically and then even more aggressively during the pandemic to support public health. And I agree with you completely that, you can't predict what you're going to need tomorrow. We get new ideas all the time from our participants of, can you do this and can you do that? Yeah. And my question always is, what outcome are you trying to achieve? What data is needed to get there? And then we have to confirm whether or not we have the data. So it usually relates to either data we already have and or data we could get if it was available and could be shared. So I think that ties back to the comment you made earlier about that utility model and being able to serve as that intermediary and support the entire community in these various areas.
Right.
Let me turn it back over to Morgan. Morgan, do you have another question for Dr. Rucker?
Just a really quick one, Dr. Rucker. I mean, you talked a lot about, technology and standards. I think one of the things that we continue to focus on here in Colorado is going back to this idea of infrastructure or utility, is the ability to solve the problem for multiple use cases. I think that we've worked for years in terms of developing registries, focused, like you said, on very specific data elements for either public health or care management and population health purposes. But from my perspective, the HIE serves a really unique role in being able to solve multiple use cases. I think one of the challenges that we always have is differentiating ourselves from kind of the multitude of technology tools that are out there. So I think it would be valuable just if you could just really, really briefly describe how you see the role of the HIE kind of playing in both the public health use cases, the direct, the supporting clinical decision making in the exam room, and how it differentiates from a lot of the tools and the technologies that you see in the marketplace, and how they're either complementary or not, and just where you see the HIE fitting in.
Yeah, I think it's really ultimately a breadth and depth type of discussion, right? It's a breadth and depth discussion. So how much data do the depth is really how much data do you have on an individual, right? And so do you have just, let's say, what's in the quote electronic health record of that individual for their primary care doc, or do you right, or that provider, that delivery system, that clinic, or do you have, again, breadth and depth over all different types of providers, all different types of settings. And I think, there's another famous law, Metcalfe's law on networks, but, these things improve exponentially. And so, especially for the sickest patients, right? And our most challenged members, right? Those are the people who, for for folks who are with agencies on this event, right? Those are the people that are using the most resources, right? The people who are going back and forth in multiple settings. They're admitted to the hospital, they're in a nursing home, they're getting home care. Maybe they have mental health issues, behavioral health issues. So they're batting back and forth between all kinds of different institutions, right? Those are the folks where the benefits are the biggest, but our societal costs are by far the biggest. So having that richness, and that's, I think, where the state HIEs are basically relatively unique. If you look at some of the other potential sources of information, they're just greatly missing it on one diameter, on one dimension or more dimensions. The other subtle thing about HIEs that I think is very powerful from a public policy point of view is HIEs are innately pro-competitive, right? Because they hook up all providers. Rather than, for example, having a dominant delivery system, put everything into their EHR, and then saying, if you don't practice in our delivery system, you don't have access to this. And we see this in many parts of the country. That's really an extraordinary push to raise healthcare costs in America. And then when you actually measure it in these localities, healthcare costs are disproportionately higher, right? So we don't want to create these expensive data islands where these walled gardens where data is locked up, and then employers and the economy have to pay vast prices to enter the walled garden. We want something that is more of a public utility point of view with reliable, consistent access to data, where the benefit is first and foremost to the patient and not to the not to specific parties. So I think that's really the surround here. Again, the public is paid for all of this data, right? Let's be very clear, right? Either directly in care through things like Medicare, Medicaid, IHS, DOD, VA, or indirectly through a very preferential tax treatment for pre-tax for much of the spend, right? So all of this is coming directly out of public resources, and the public should have an unfettered right to what they paid for.
Absolutely. And we have structured certainly ways that we can work with the third-party vendors and technologies that our stakeholders want, so they can use the different tools and technologies that are out there.
Yep.
My next question is going to be a bit related to some of those last comments. I mean, Dr. Rucker, that we've worked with you and your team throughout the pandemic, because there still are challenges with getting certain types of information, certain sources of information shared through the HIE system. And some of us in the HIE world have more challenges than others. And certainly you've been involved in a lot of federal policy considerations at the federal level. So I'm interested in your take. I mean, I think I have a policy background, so I'm just innately intrigued in this area. As we look ahead, and even in Arizona, we're considering what should, as a community, we look to change from a state policy perspective, whether that be laws, regulations, policies, et cetera, and that certainly that balance with federal laws and regulations as well. Do you have comments as to where you see that balance and what states should consider? I know, just for instance, we're even looking at some of the hospital discharge reporting requirements and working collaboratively with stakeholders to identify how that burden can be reduced, as we're working on reducing other burdens related to COVID reporting, but some of those things are in legislation. So what is that balance, and what would you advise us as a community to consider when we're looking at our state policies versus what may be going on at the federal level?
Yeah, I think certainly, there are certain policies that are state level, right? Some of the payment policies are obviously federal, but things like, state Medicaid programs, I think, the state Medicaid program should be designed as a general rule to incent use of health information exchanges. There's no reason the state Medicaid programs should be paying for care twice or providing, inefficient care to patients because, the other information hasn't been accessed. So that's, for example, a very large population that, as we know, it's often quite challenging to get histories on, to get consistent stream of their clinical information. I think states should start thinking about their various privacy laws and other social welfare programs, community information exchange. How can this be put into to utilize the infrastructure that the health information exchanges have built up rather than flying blind? If you look broadly in the US, our social welfare agencies, looking broadly, don't really coordinate very much between the various programs. Now, a lot of reasons for that, but they really don't. If you compare it to, in the private sector, something called customer relations management, CRM, Salesforce is a company that most famously has pioneered here. We should have those kind of features so that no matter what public welfare program folks are in, that there's coordination of that information, especially since many of these things but immediately into medical issues and medical care, whether it's classic medical care, behavioral health, opioids, all of those things. So that there's no crisp boundary there. So these things should be, I think, looked at as policies. And then I think the other thing that is something that states should look at and, work together, National Governors Association maybe, is thinking about, can we do better as a country on consent models, right? I don't think as a country we've solved consent. So I think that's something, it's very tempting for state legislatures to, pass a law that has some privacy provision or something. Typically this is with minors or drugs or pregnancy. Those are the things, or folks, who aren't able to take care of themselves. I think there's an obligation for states to really work with their health information exchanges to make sure that these things are practical and provide the protections, but provide, don't preclude the benefits of sharing. So those are I think some of the big things that are out there.
Absolutely.
Melissa,
And go ahead, Morgan.
I was just going to chime in there because I know you want to transition to kind of social determinants of health, but Dr. Rucker, I would just add that one of the really unique projects or programs that we've got with the state of Colorado is to support just what you described, and whereby we're using our master patient index to help identify the folks that are in those different welfare or social services types of programs, so that the Medicaid agency understands, if you've got a person that's got food insecurities and maybe they're on the WIC program. We did a program last year to kind of evaluate the eligible but not enrolled across different programs. And in my mind, I do this all the time. So it's an easy correlation for me. But when you talk about consent, you have to be able to put the patient in the middle of that consent kind of broker. And so again, from my perspective, just a perfect place where the HIE can support systems, patients, state agencies, different social service programs. And then I think that immediately takes us into kind of where we play in the social determinants of health role. And I know that that's what Melissa wanted to tee up next. So I just wanted to interject there.
Yeah,
Absolutely.
spot on.
Yeah, is there anything, because we are certainly advancing a pretty robust social determinants of health effort here in Arizona, and I know that your office has done a number of things in that social determinants of health or community information exchange space. We're looking to procure, in collaboration with Medicaid, a statewide closed loop referral platform and implement that in the coming years. Is there anything that you would share with the community here of things to, keep an eye out for, to consider as we're starting down that road, and really have started down that road, but as we continue to evolve that and how it links through to all the work we already do on the clinical information side?
Yeah, I think a lot of this is early. There are data standards on what's shared, but I think, frankly, just ADT type of information, admit, discharge, transfer type of information. You're in this service or this facility or this program, you've exited this service, facility, or program. I think even that kind of information is very powerful, and building up an app that these agencies can use to hook up to your HIE to get these simple ADT feeds. There's some, I think, low-hanging fruit that can be very, very powerful here, right? This does not require you to ship some existential record of Freudian analysis of genetic analysis of why the patient has this, that, or the other. Sometimes it's just where is the patient? Who's taking care of the patient? If you're sitting in the ER, I've had thousands of patients that I've just wondered, I know who sent them to the ER typically, but I don't know who sent them to the person who sent them to the ER, right? I don't know anything about their prior trajectory that would allow me to help and the team to provide effective care. And obviously the goal is to not have the people use the ER for these failure modes, right? The goal is that these ADT feeds can be used well before people come to the most expensive, least efficient part of the food chain, right? That we know where these folks are, and can start tailoring programs that are not silos.
Absolutely.
It's the basic power of computing and virtual versus bricks and mortar type of stuff. We don't have really any of that information in the social welfare program, as far as I can tell.
Yeah, well, we're working with them regularly these days, and we look forward to continuing to collaborate with your office so that we can learn from everything else that's going on across the country from our HA colleagues and from others. So I think that about wraps up our time. I want to thank you again. Thank you, Morgan, for joining us for this discussion portion of the presentation. For those of you in the audience, we're going to take about a 1-minute break. But thank you again to our keynote speaker, Dr. Rucker, and we will join you back here in just a moment for our Health Current update.